Good evening, friends. A warm welcome to this episode of 4D, Detailed Discussion and Dialogue in Indian Diabetes. This is season 3.0 of 4D going on, and we are going strong. Today, it's a great pleasure to be able to welcome three dynamic doctors from Maharashtra, from Navi Mumbai. A warm welcome, first of all, to Dr. Tamiruddin Danwade, who is consultant interventional cardiologist at Mother and Rhythm Clinic, Navi Mumbai. Warm welcome, Dr. Tamiruddin.
Thanks a lot, sir.
Dr. Tamir, this Dhurandhar craze is going on these days, and there's a question from the house for you. And they say, Dil chura ke le gayi. So, this is from a song from the movie, and the question coming to you is, who has stolen your dil? Aapne apna dil kisko diya?
Yeah, so I can say I have given my dil to my profession itself, to cardiology and to medicine.
So, that's a perfect match, and thank you for doing that. Thank you for taking care of all your patients and their hearts. Thank you. It's an equally great pleasure to be able to introduce Dr. Purva Bhavekar. Madam is a nephrologist and transplant physician at Utkarsh Hospital in Sambhajinagar. Warm welcome, madam.
Thank you, sir. Thank you for having me.
Ma'am, there are so many songs in Dhurandhar movie, and many of them actually are so directly related to nephrology. The first song, actually, the title song says, "Dance for me, let's dance together." So the left kidney and the right kidney, do we need separate specialists for these, or do you think one specialist can handle both kidneys together?
So one specialist can definitely handle both kidneys together, and we should have a synchronized dance. Otherwise, it's going to be a havoc.
That's true. Thank you so much. And along with us is Dr. Parag. We'll introduce him shortly, and we'll have a synchronized dance over today's 4D. Thank you, madam.
Thank you. So, jab tak they dance together, everything is well. The moment they start having an unsynchronized dance, everything goes haywire. So,
So,
in medical terms, we have to have a synchronized left and right kidney dancing.
yeah, that's nice. And Dr. Tamir is back with us. So, Dr. Tamir, your answer had got censored actually because of multiple reasons, just like Dhurandhar has been banned in a couple of countries. So, the question coming from the audience is, the Dhurandhar title track says, Na Dil De Pardesi. The question is, whom have you given your heart to?
Okay, means you are asking me, sir?
Yes, yes. And Abhi, so you wait for the question that's going to come to Dr. Parag.
This is non-academic, I hope.
Yes.
To cardiology, maybe.
To cardiology, that's true. So thank you for that. Dr. Tamir's heart lies in his work, and it also lies in his interventions and in the hearts of his patients. So he has given his heart to multiple people whom he takes care of.
Correct.
And nephrology, like Dr. Purva said, Nal Nacho, you have to dance together. So all the subjects have to dance together. But when we speak of diabetes, our forum is detailed discussion and diabetes, detailed discussion and dialogue in diabetes. We need to have an expert from endocrinology as well. So a great welcome. Let's share three cheers for Dr. Parag Agarwal, who's a consultant endocrinologist at the MGM New Bombay Hospital, Navi Mumbai. Warm welcome.
Hi, sir. Good evening, sir. Thank you so much for having me.
Thank you, Dr. Parag, for being with us. Now, the heart weighs around 250 grams. The kidneys weigh 150 gram apiece. Even if, let us say, somebody has a myocardial infarction, undergoes myocardial necrosis, the person can survive. Even if the person undergoes a nephrectomy, of course, things do go haywire, but Dr. Purva will be able to take care of that surviving kidney and we'll be able to manage, even if 150 grams of kidney goes away. But the beta cell weighs only 0.8 grams. So, what do we do if that 0.8 gram goes away? Supposing somebody does a shararat, the same way in Dhurandhar, there are lots of shararats going on. So, somebody does a shararat or some naughty hanky-panky with the beta cell. What happens to our metabolism?
Needless to say, the beta cells of the pancreas, they produce insulin. They also coordinate with the alpha cells, the glucagon and everything. And obviously the metabolic profile will go haywire. The sugars will keep on rising and they won't be under control. So at that point of time, we need to give exogenous treatment for the patient, maybe in the form of insulin, other drugs, or maybe pancreatic transplant.
But before that, now there is lots of stuff that we can do to protect our patients. We can protect their heart, their kidneys, and their pancreas through multiple therapies. in today's journey. Now, in Dhurandhar, they sing, "Na koi karwan ki talash hai, na koi humsafar ki talash." But in today's episode of 4D, let's be humsafars together with each other, all of us from across India, listening to each other, and together with our patients. And let's focus on women's health. So let's join the karwan or the caravan of a woman's life, her journey through life, and let's look at various phases. Let's see how we can be a humsafar for her life. So we'll begin. We assume now that the lady has become an adult and she's of reproductive age group and she has reached the preconception phase. We always talk of preconception counseling, preconception screening. But Dr. Tamiruddin, from a heart perspective, from a cardiac perspective, any things that come to your mind? What should we screen for when a woman with metabolic syndrome, a woman who is at high risk of metabolic disease, is planning pregnancy?
Yeah, so in modern era, modern life, obesity is increasing, and with that, diabetes, hypertension, and also coronary artery disease is increasing in younger age group. And as we used to consider, women are not young women, young females are not at a risk, but nowadays that concept is changing, and because of maybe food habits, stress, lack of sleep, younger women are also contacting, also suffering from coronary artery disease, apart from diabetes and hypertension. So every adult female who is especially obese at higher risk should undergo few tests: fasting lipid profile, sugar levels, thyroid levels, and maybe ECG, 2D echo if required, to check whether there are any congenital heart diseases, whether there are already some cardiomyopathy, any LVH which can adversely affect the pregnancy and its outcome.
Could you just share some anecdotes from your practice? Now, you said that we should do a 2D echo as and when indicated. Let us say I am an adult healthcare provider, maybe an obstetrician or perhaps an internist. What are the red flags in maybe a 35-year-old lady? She's planning pregnancy. What are the red flags which should prompt a referral to a cardiologist for pre-conception checkup?
So any palpitations, breathlessness, lower limb edema, that is signs of heart failure, should the doctors, the gynecologist should refer the patient to a cardiologist and promptly do a ECG and 2D echo to rule out already existing diseases. But in high risk cases, maybe obese lady, again without any symptoms, better to do a 2D echo because it is a non-invasive test and we can easily rule out the pre-existing heart diseases. So that is the whole idea.
Thank you so much for raising all these points. And we understand that marriage and pregnancy both are occurring later and later in our country. And all the metabolic disease, including coronary artery disease, occurring earlier and earlier. So we do need a screening. At least screen your patients clinically. Keep a cardiac mind style also while you are screening. And if required, do not hesitate to get an echo done. Do not hesitate to refer to the cardiologist. You will be actually rewarded, both the patient and you. If there is any issue, we can sort it out before pregnancy starts. Otherwise, during pregnancy, it becomes very difficult. Dr. Purva ma'am, when we have patients with diabetes or with metabolic syndrome, when they go into pregnancy, it is said that pregnancy is a stress test. It is a stress test for all the endocrine and metabolic glands of the body. And sometimes the patient is not able to overcome that stress test. Specific issue we have with the microvasculature, retinopathy, nephropathy, all these worsen. So, ma'am, your comments in the modern era, what would be the pre-screening, the preconception screening from a nephro perspective?
So, if I have like a minute more, I'll be able to elaborate on this because it's a beautiful topic to have as far as pregnancy and preconception planning is concerned, especially in the background of preventing kidney disease or having a pre-existing kidney disease and how to go about it. So in the scenario where you do not have any kidney disease or any ailment, it's okay just to screen all your organs as a routine and go ahead with whatever your gynecologist says. But let's say, since you have already pointed out the fact that people are getting married later in life and conception is happening probably after mid 30s or late 30s or early 30s. In these scenarios, when the risk of GDM or the risk of gestational hypertension increases multifold, as it would be if you conceive in your 20s. Also, the point or the fact that pregnancy is a stress test, I'd like to elaborate on this by comparing our body to probably a car. So let's say if a car is used to running at a speed of 60 kilometers per hour in a very smooth manner, that is the normal for that car or that individual. But pregnancy is like you are running at a speed of probably 120 kilometers per hour for 9 months, almost 36 to 40 weeks, and this is happening 24/7. So in that race where you have to all your organs are on a accelerated mode, you have to have baseline reserve, which is very important, because if you have a baseline hypertension or diabetes which is not detected prior to pregnancy, that will also get accelerated and will lead to problems. So my suggestion to everybody who is conceiving probably later in life, because that is a very high risk pattern that we are observing, is you most importantly check your blood pressures, and not just one reading, but probably a 24-hour blood pressure monitoring would be the ideal scenario for any women planning pregnancy, especially if she's obese, especially if she's pre-diabetic with a HbA1c of probably 6 and 6.5, somewhere in between. And also patients or individuals who have a family history of some sort of a kidney disease, heart disease, diabetes, hypertension, and any lifestyle disorder. Even these individuals should be screened for probably thoroughly investigated before they plan for pregnancy.
This also makes sense, and this resonates with us as well, especially with people who work with obstetric medicine, because so many times during pregnancy, our patients get into trouble. They might get albuminuria, they also get retinopathy, worsening of retinopathy. And when you are screening properly for nephropathy, that is also like a surrogate screening for retinal health. If you have been able to pick up albuminuria, that means you have to focus more on eye health, on retinal health.
Right.
Dr. Parag, in Dhurandhar, the hero enters, Ranveer Kapoor enters with the Fastla song. That's a song of celebration. It's a song of positive vibes. Now, what do you think? Pregnancy is something that we celebrate. It's a happy moment. But before pregnancy, now we are telling the patient to undergo so many tests. Is that depressing? How do we counsel the patient? How do we tell her that actually we want you to have a great experience? We want you to have that positive fasla, the positive vibes during pregnancy. How do we explain all these tests to the patient?
Yes, sir. That's something very important, that how we communicate with the patient about what is expected of the tests. We can explain to the patient in a way like, if we're able to pick up a disease early on, we would be able to target the treatment in a better way, such that we have a better long-term outcome at the least possible expense and with the best possible, benefit. Providing a positive reinforcement to the patient of what good can be achieved or what bad can be relegated to a side, that serves as a positive feedback for the patient. And also scheduling the proper evaluation with the proper time period of the patient, for example, around the puberty, around the preconception, at the time of conception, and immediately post delivery. So those are the time periods when the patients are most overwhelmed, and a proper calming sound and a calming discussion with the patient can go a long way. So it all lies about how we place the words in front of the patient such that it looks as a rewarding outcome rather than as a homework to be done for the patient.
So that's right, and thank you so much for reinforcing this. Whether we are physicians or we are obstetricians or maybe infertility specialists, whatever kind of healthcare setup that we work in, again, the inspiration is from Dhurandhar. The song "Easy Easy" make things easy for the patient. Don't scare her. Don't make her feel
Yeah.
afraid. Certainly, do not depress her. What we say is that we want to create a good foundation so that we can create a good building. And it's not just about starting pregnancy, it's about sustaining pregnancy. You need to sustain till term, and it's about having a safe and secure pregnancy with the right outcome, with a happy baby and mother at the end. Sometimes, just to make things easy, we use the ABCDE concept, and we call this transgenerational karma. So the word karam or karma in Sanskrit, that is past tense, present tense, and future tense. Everyone understands what karam is. So we tell them that whatever karam you have undergone or you are undergoing or you are experiencing before, during, and after pregnancy, the same will apply to the next generation as well. A, B, C, D, E, very easy to remember. A for anemia. Don't forget that. The fact that we are an internist doesn't mean that anemia should be looked after only by the gynecologist or by the primary care physician. It is our responsibility as well. Our next question to Dr. Tamir and Dr. Purva will be the impact of anemia and hemoglobin in cardio and nephro. So A for anemia. B for blood pressure. Rightfully mentioned, you have to be very careful. Be aware that the definitions of hypertension in a non-pregnant individual and a pregnant individual are different. C is for circumference, which we mean to with which we explain obesity. Again, Dr. Purva mentioned that. So A for anemia, B for blood pressure, C for obesity, C for circumference. Manage that before pregnancy starts. D is for diabetes or dysglycemia. Dr. Parag will speak to us in greater detail. And E is for endocrine as well. Endocrine factors like TSH, for example, prolactin. If required, you look after them. So if you are able to handle the ABCDE, the transgenerational karma, the impact on the mother and upon the fetus and the unborn baby will be beneficial. If you do the right karam, you will get the right karam. We can also use other methods. So the Arabic or the Punjabi word is kufr. Metabolic kufr means all the sins that you do. If you can, let us say you did a kufr in the past, maybe you were smoking, maybe you were drinking, maybe you didn't take care of your blood pressure. You can always do what we call in Punjabi or Arabic amal. So you can do the right metabolic amal, you can take the right metabolic actions now, so that later on you will get the right metabolic outcomes. But we come back to A for anemia. So, Dr. Tamir, how frequent is anemia in a cardiology perspective? Have you burnt your fingers? Do you feel that we overrate anemia or maybe we underrate it?
No. Anemia is still very common, especially in ladies, and even in younger ladies also we are finding very frequently that causes adverse effects on pregnancy, postpartum, peripartum, during the pregnancy. So anemia should be taken care of. Now we are more aggressive in managing the anemia. Even uh, hemoglobin is around 10, we give iron supplementation even though hemoglobin is about 10 to prevent the complications. Anemia for heart cardiology perspective, it causes increase in heart rate, increase in oxygen demand, and if already patient is having any congenital heart disease, any coronary artery disease, the complications will increase definitely, and pregnancy outcome will also pregnancy or any age group female will be adversely affected by the anemia.
So we begin with A. And Dr. Purva, from a nephro perspective, hemoglobin is said to be a Goldilocks metabolite. Goldilocks means neither should it be too much nor should it be too little. So what is that perfect Goldilocks range for hemoglobin in women with CKD? And any anti-diabetic drugs coming to your mind, madam, which may increase hemoglobin or which may reduce hemoglobin by causing hemodilution, like maybe pioglitazone. So, from a nephro perspective, CKD perspective, how do you approach anemia?
So, as far as we're talking about pregnancy, CKD, or we're just talking about anemia and pregnancy, I'd like to have a clarity on that.
Anything that comes to your mind, whatever you see in the OPD in both men and women.
So, when I'm seeing somebody in the reproductive age group having anemia, of course, I think when the obstetrician is referring the patient to me, they've already ruled out, I assume, nutritional and thalassemia. But as far as chronic kidney disease is concerned, we need to have a very strong clinical acumen to rule out chronic kidney disease. It just so happens that anemia may be the only predominant sign wherein everything else, all the parameters may be normal, and they might just have small shrunken kidneys or borderline kidneys. In these scenarios, the cause of anemia can be CKD, which should not be ignored. Apart from that, as you said, any diabetic medicines that cause anemia, I'm not very aware of. But anything that increases or decreases is like a MCQ question for me at this point in time.
Of
But
course,
I
of
haven't
course.
seen anything in long run wherein anti-diabetic agents that we use, which are renal safe, causing anemia. Like for example, as far as SGLT2 inhibitors are seen, I haven't seen
Yeah,
somebody
they
having
actually
anemia.
improve. Yeah.
Yeah,
Dapagliflozin actually will improve hemoglobin because it acts upon the not only upon the tubules of the of
yeah,
the nephron.
the peritubular, yes,
So,
peritubular
Doctor,
capillaries.
yeah. Dr. Parag, from an endocrine perspective, any drugs that may cause hemodilution and cause low hemoglobin, and dapagliflozin and the kidney, how do you view it from an hemoglobin perspective?
Yes. So pioglitazone, we are all aware that it can cause dilution of hemoglobin because of retention of fluid in the body. So look, because hemoglobin is tested by the machine, which looks at the concentration per cell, and because of the hemodilution, the hemoglobin would tend to be on the lower side. And about the dapagliflozin, we are aware that because it has a positive effect, because it reduces the inflammation, because it increases the erythropoietin level, because it also decreases the inflammation. So all of these causes can help the patient improve the anemia. May not be to the extent of what we expect with the blood transfusion or iron therapies, but definitely it has a positive impact on the anemic status of the patient.
So it helps in women with CKD. And then again, the Dhurandhar song Ishq Jilakar. So agar Ishq Jilakar chala gaya, if let us say we've burnt our fingers and we've already got CKD, or maybe we've got early stages of heart failure, dapagliflozin will be helpful. It will help us calm that jala hua ishq. It
Yes.
will help us calm the fire of unwanted love from kidney disease, heart disease. But let us reinforce that when your patient is in the pre-pregnancy state, in conception state, then concomitant medications are a major issue, and it is all our responsibility for all of us to make sure that no wrong medicine is given to the lady, which can have even the tiniest of teratogenic effects. So let's go one by one. Dr. Tamir, any common, now let us say I am a lady and I have been taking treatment for you from for hypertension, for heart failure, any kind of cardiac disease. Now I come and say, sir, I want to plan pregnancy. What are the drugs that you would start? What are the ones that you would stop?
Yeah. So it is very important. Many of the drugs, antihypertensive drugs, are teratogenic or can cause dehydration and affect adversely in pregnancy. So, especially in young age, hypertensive patient, we start ARBs, ACE inhibitors. These are teratogenic drugs. These should be stopped and replaced by safer drugs. Even beta blockers are better to be replaced by safer drugs, generally by calcium channel blockers or others. Diuretics also can cause dehydration and can cause complications. Those also should be replaced. Then statins again sometimes cause teratogenic effects, so better to, if the cholesterol level, triglyceride levels are under control, those can be stopped temporarily.
Dr.
Then
Purva, yeah, yeah, sure,
anticoagulation,
carry
the important question, anticoagulation. But anticoagulation in first and last trimester, if patient is on acetylcholine, warfarin, that if possible we should replace it. But in countries like India, where acetrom is already there and patient is pregnant, and it can be continued if there are no complications with routine follow-up. Yeah.
Otherwise, is low molecular weight heparin safer in pregnancy and after pregnancy?
Yeah. Whenever it is possible, we should change over to low molecular weight heparins. So newer Novax and all these drugs should be avoided. Data is not available.
Dr. Purva, from a renal perspective, any changes that you would like to make and there are so many medicines in a CKD prescription. So anything that you would like to change in a woman who says, I want to come and plan pregnancy, I want to plan pregnancy?
Yeah. So, talking about CKD patients who are stable CKDs, I'm talking about CKD2, CKD3. This is the common population in case they want to plan pregnancy. SGLT2 inhibitors and even finerenone, for that matter, is not indicated if somebody is conceiving. So these medicines, the SGLT2 class, that is EMPA, DAPA, CANA, they should be avoided. Apart from that, we see a lot of transplant patients planning to conceive. So transplant patients usually are on mycophenolate, tacrolimus, and steroids. And we usually advise them not to take mycophenolate for at least a minimum period of a year before planning pregnancy, and we switch them to azathioprine. So this is my basket, wherein sir has already mentioned about statins, ACE inhibitors, ARBs, and warfarin and acetrom. But apart from that, as far as nephrology is concerned, it's not specific, but only the transplant line I would be very specific about, that we switch from MMF to azathioprine in case these patients are planning to conceive.
Thank you. Dr. Parag, from an endocrine perspective, if you could take diabetes and other endocrine diseases as well. So because our training and our practice is also changing. So first of all, diabetes, but then other things like maybe the person is on bromocriptine or letrozole. So what changes do we make when the patient comes and says, I want to conceive?
Yes, sir. So it is not very uncommon for endocrine entities to coexist in a diabetic or in a pregnant lady, the most common being diabetes mellitus. So we know that insulin is the safest anti-diabetic drug that is available for patients with pregnancy. But we also need to know that metformin. We have a lot of data that metformin can be safe in these patients, provided we select a proper group of patients. We monitor the fetal parameters, we monitor the mother's parameters, the metabolic parameters, the blood pressure. So that can be a safe option. It is not uncommon for PCOS patients or polycystic ovary syndrome patients who have been prescribed metformin early on for insulin sensitization, and they get pregnant and they come to us with metformin. So in those cases, the data are available that it can be continued provided we follow the patients with those parameters. PCOS also, they are often taking aldactone or spironolactone, but then that is not allowed in pregnancy because of its androgenic effects. The oral contraceptive pills, needless to say, they won't allow pregnancy to happen if they are on board. Moving on to osteoporosis part, the calcium, vitamin D, they are essentially safe. Rather, as we go towards the third trimester and immediately in the postpartum period, those are the most important drugs that need to be supplemented, the calcium and vitamin D, because that is the period when pregnancy and lactation associated osteoporosis usually sets in. Another important drug is thyroxine. Thyroxine is safe. Important point is if a pregnancy is detected, the pre-pregnancy dose of LT4 or levothyroxine has to be increased by 30 to 50% and then followed up with endocrinologist. The anti-thyroid drugs, as we know, propylthiouracil is generally preferred in the first trimester, not because it is totally safe, but because it has lesser side effects as compared to the neomercazole or methimazole, carbimazole that we know. And from the second trimester and third trimester, the carbimazole, methimazole can take over. But having said that, both of these drugs do have the list of fetal toxicities and those need to be followed. Moving on to the prolactin part, the bromocriptine, cabergoline. So earlier what we had data was on bromocriptine, which was said to be safer. But now we even have a lot of data on cabergoline, and we know both of them can be safely continued in pregnancy. provided we follow the patient in a proper way. We do not follow these patients with serum prolactin or the MRI reports because we know of the physiological changes that can happen. And it is the clinical parameters that need to be taken in care.
Thank you for summarizing this.
And about the
But
GnRH, yes,
yeah, yeah. So, but thank you
yes,
for
sir, please go ahead.
summarizing this. But then, as we see again from the movie, गहरा हुआ ये सब गहरा होता जा रहा है. Things are becoming deeper and deeper, and then many of us will say, let's come back to simple things. So let's just summarize that the antihypertensives, the anticoagulants, the anti-cholesterol drugs, the antiplatelet ones, all of them have to be reviewed when the patient comes to you for preconception. If she has turned up first to women's health, please refer her to the appropriate specialist, to the internist, and if required, to the transplant physician, to the nephrologist. If the person is already a transplant patient, or maybe a heart failure patient, or someone who is on acetrom, she will be following up with a cardiologist or a nephrologist. Remind her to go back to them for another checkup. Another mistake that we make many times now in pregnancy, ACE inhibitors and ARPs both are contraindicated. So is spironolactone and so is finerenone. But after delivery, you can give enalapril, you can give lisinopril. So if you are struggling with blood pressure postpartum, do not feel afraid to use enalapril and do not feel afraid to use spironolactone. These are safe during lactation. Because of an unnecessary fear, we sometimes do not use these drugs in the postpartum phase. Also, be aware of the dietary and culinary practices which influence blood pressure. So, in winter in North India, for example, the moment the patient reaches third trimester or is in postpartum phase, they begin force feeding her a lot of ghee and a lot of salt and oil, and that actually makes the BP jump. You get accelerated hypertension. So, proactively counsel the patient just to take food in moderation and to not to take anything that is very high in salt or very high in ghee. But we'll move on. We've talked of preconception. Now our patient has become antenatal. And now Dr. Tamir, suddenly she begins to complain of breathlessness. And you feel that there may be a cardiac issue. So, sir, question to you is, what are the common cardiac conditions that may worsen during pregnancy? And how do we keep a high index of suspicion for them? Patient did not come to us for preconception counseling. Now she has come in maybe second or third trimester. How do we think from a cardiac lens?
Yeah, so already existing diseases, especially in India, historically valvular heart diseases, rheumatic heart diseases, where mitral stenosis can cause pulmonary edema, breathlessness, heart failure, and patient can come with breathlessness. Second, any congenital heart disease, especially VSD, can present with heart failure in during the pregnancy. ASD generally is well tolerated during any form, during delivery also, during cesarean section also, high risk pregnancy also patient can tolerate with ASD, but VSD patient may not tolerate. Any primary pulmonary hypertension, it is most dreaded form of heart disease where patient have high risk. Then coarctation of aorta, patient has very high risk. So all these things should be ruled out, and if required, treatment should be done. The most golden period is the best period is second trimester, where we can do some intervention and salvage the pregnancy and the fetus. Then apart from that, nowadays we have to rule out coronary artery disease also in young females. And in third trimester, peripartum patient can develop peripartum cardiomyopathy. Previously good heart, previously good ejection fraction suddenly can fall. That also should be ruled out by doing a ECG and 2D echo. So again, I will reinforce, whenever it is possible, simple 2D echo will rule out many things.
So let's revise. First of all, we did an ABCDE for the transgenerational karma, which all of us should focus on before, during, and after pregnancy. That was anemia, blood pressure, circumference, which means obesity, D for diabetes, dysglycemia, and E for endocrine factors. Another ABCDE, which paraphrases what Dr. Tamiruddin just taught us. Any of the following red flags: asthenia, breathlessness, cyanosis or blueness, D for distress, which can be maternal distress or fetal distress. Do think of the heart. And E would be for edema and exercise intolerance. So simple things A, B, C, D, E. Again, easy, like we learned from Durandar. Asthenia, breathlessness or blueness. C for cyanosis. D for distress, either maternal fetal, and E for edema or exercise intolerance. Dr. Purva ma'am, would nephrology, would the red flags be the same or would there be different flags? Maybe urine output. What happens to EGFR in pregnancy? What happens to urine output? And what are the red flags that we should be aware of?
So, preconception, as we already mentioned, that blood pressure should be very strictly monitored when you're planning to conceive. Once you've conceived, is somebody having kidney disease in the background, their illnesses may flare up. Like, for example, somebody's having lupus nephritis, somebody's having a glomerular disease with pre-existing some amount of proteinuria, and that proteinuria just, let's say for example, it is just 0.2 milligrams per grams, that is this UACR which we're talking about, that just jumps to 2. Or maybe somebody's having baseline trace proteinuria on a urine dipstick and that goes to 1 plus proteinuria. That is alarming. That should be a red flag. That should be investigated. Especially those patients after 20 weeks, if they are having preeclampsia or PIH or symptoms like that, and if they have de novo proteinuria or accelerated hypertension, in these cases any changes in the creatinine will also suggest that some amount of renal injury is occurring. Usually what happens is there was a study wherein week-wise creatinine was being followed up for patients, and what they found is that creatinine usually dips because of dilution, and it is normally it is 0.5 in pregnant women, and in non-pregnant women it goes up to 0.8, 0.9. So any deviation from baseline should be considered and should be a red flag for a nephrologist or for the obstetrician who's also looking at the labs. And lastly, apart from all these illnesses, I would say somebody who suddenly just stops having or passing urine. UTIs are very common in pregnant women, and they should also not be ignored. Sometimes they tend to have hydronephrosis, hydroureter, and these are a physiological finding. Hydroureter is a physiological finding when it comes to the 9th or the 8th month, and there's a very you have to clinically distinguish between if it is pathological or physiological. But if somebody is having UTI, pyelonephritis, that can complicate the pregnancy, and in these cases you need to have the use of non-teratogenic antibiotics that can be given in these patients. So these are the few red flags that I think of at this point in time. There are plenty as of now if you keep on going into the depths of it, but superficially these are the ones.
Actually, these are the important ones, and thank you for sharing them with us. Let's do another ABCD to simplify things for us. Easy, Dhurandhar style. A for albumin, and our obstetrician friends use albumin as a risk stratification tool as well. The moment there is more of albuminuria, they know that there is a stress on the placenta and they have to terminate the pregnancy. A for albumin, B for blood pressure. Dr. Purva has repeatedly mentioned that you have to cross-check, recheck, double-check the blood pressure during pregnancy. Do not make a mistake there. C would be for creatinine, and she has pointed out that the thresholds are different in pregnancy and in non-pregnancy, just like for blood pressure. One common, we'll ask Dr. Parag that we have this paradox in endocrine practice, actually, where the serum creatinine comes down. We know it is because of malnutrition. We know that the CKD is being mismanaged, but the patient feels very happy that, I went to the alternative care provider. He has brought my creatinine down, which all of you were not able to do. And similarly, when the patient gets into hypoglycemia, we feel afraid. It means the serum creatinine is rising. The kidneys are going to conk off. But the patient feels very happy and they say, you've been mismanaging us for so long. But A, B, C, D, E, A for albumin, B for blood pressure, C for changes in creatinine, and D for diuresis, sudden changes in diuresis. And to continue with our ABCDE, E would be for eyes. If there is a sudden change in visual acuity, do get a retina checkup, and at the same time, do get a kidney checkup. Do not ignore the kidney when the patient comes to you with change in visual acuity. But Dr. Parag, coming back to this concept of this paradox, serum creatinine comes down. Is it always good? Hypoglycemia occurs, glucose comes down in somebody with uncontrolled, long-standing uncontrolled diabetes. Is it always good?
No, sir, definitely not. Hypoglycemia is something to worry more than hyperglycemia. Definitely not.
And we should worry about renal health here as well. So we have talked of preconception, we've
Definitely.
talked of pregnancy. Now the lady has delivered, and now she says, "I want contraception." So, Dr. Tamiruddin, especially with the newer drugs in cardiology, what are the common drug-drug interactions? And the question coming from the audience is, does the cardiologist always take a history of contraception? Or is cardiology still a male dominated kind of a field where nobody is bothered about women's health? Nobody is bothered about contraception and the drug drug interactions?
Definitely not. So we regularly check the contraceptive history, especially be more worried about the rather than drug interaction. We are more worried about the coronary artery disease risk about the contraceptives.
Yes.
Especially patient is high risk. Estrogen based therapy is more riskier than progesterone based therapy, and non-steroid based contraceptives, IUDs and all are better. We regularly counsel the patients these things, and definitely many drugs have interactions with the estrogen and progesterone based contraceptives. So whenever it is there, we'll change the medications accordingly if the history is there. If we ask the patient to stop or change the contraceptive itself.
And there should be crosstalk between all of us in women's health and in metabolic health. Another big red flag would be triglycerides. So when you give oral estrogen, which is part of all the COCs, combined oral contraceptives, triglycerides might rise. Also be aware that all estrogens are not the same. The estrogen, the progesterone that we use in menopausal hormonal therapy is different from what we use in contraception. The doses are different. The route of administration is different. In general, transdermal estrogens will be safer. So, if there is an issue, let us say you are a physician, you found a triglyceride of maybe 450. Now you want to fix it up. Take a history of contraception. Even if you don't know all the names, a simple thing like in Hindi, कोई माला डी जैसी दवाई या प्रेगनेंसी रोकने के लिए कोई दवाई तो नहीं ले रहे, that one sentence is enough. The lady will say yes or no. And supposing you feel the triglyceride is high, you might write a note, consider local therapy, consider IUCD, consider transdermal therapy, and you should not change it yourself now if you are an internist, but you refer back to the person who prescribed it in the first place. Dr. Purva, how about contraception and nephrology? Have you burnt your fingers? Patient, we never spoke about contraception in the first place. Earlier, the patient had such bad glucose, such bad azotemia. So, I mean, where would she conceive from? You gave the right medicines, the metabolic milieu came back to normal, you fixed up the acute kidney injury, you stabilized the CKD, and now suddenly the patient comes with an unplanned pregnancy. Has it ever happened, and how would the nephrologist handle it?
Recently, I have had a case where a transplant patient had conceived, and we didn't find out that she conceived after, even if she was with us for 3 months, because she never told us. Her family size was complete. She had 2 children, but it just so happened that she presented with DVT, and everything went well. We were giving her enoxaparin, and one fine day, she said that I've missed my period, and she just got a UPT done, and she just found out that she's pregnant, and it was probably, I think, 8 or 9 weeks, and it was a shocker for us. But this has happened that. I will begin with a transplant case, because those patients, their fertility returns to normal, and these are kidney disease patients who have received a kidney transplant, and they have conceived well. But as far as CKD cases are there, wherein it is assumed or it is known that fertility becomes a problem, especially when the kidney disease is advanced. In such cases, it does not mean that reduced fertility is not equal to no fertility. And in such cases, contraception should be intentional and it should be kidney safe, rather than just declaring that, I'm not fertile, or, whatever be it, I may not conceive. So in CKD cases, contraception should be intentional. And as far as contraception is concerned, we prefer progestin only pills. The reason being that estrogen is does cause the salt and water retention. It also causes thromboembolic events, we are all aware of. But salt and water retention will accelerate the blood pressures and lead to hypertension. And this is what we don't want in our cases. So estrogen pills are contraindicated, not contraindicated per se, but best avoided.
Yeah.
The other contraception routes, as we all know, barrier methods are preferred in all CKD patients, and even IUDs are preferred. But again, you might have some sort of an anemia linked to IUDs, because you'll not be able to differentiate between CKD anemia and anemia due to a copper IUD. Probably some amount of bleeding is happening. And I'd say, yeah, that's about it.
And this is a really important factor. So, first of all, thanks to all our speakers, all the Dhurandhars from cardiology, from nephrology, from endocrinology for handling this topic. And an even greater thanks, a louder thanks to everyone from across India who's listening to us. And this reminds us that we must talk about contraception to all our patients, to men, to women, even to the younger people. Though I personally find it very difficult now. I'm from the older school, but we see that sexual activity occurs much, much faster. So if you don't talk about it, or if you don't convey to the patient that yes, I am there to help you, they will go to the wrong person for help. Things will become worse. Dr. Parag, an endocrine perspective, uh, contraception and the newer anti-obesity medications, anytime that you've burnt your fingers. And then a question from the audience is, UPT will be positive at 10, 12, 13, 14 weeks, but somebody with 5 months of pregnancy, 6 months of pregnancy, the patient doesn't know. She says, I have ascites, or maybe I have fluid overload, or maybe I have heart failure. 6 months of amenorrhea. Would it make any kind of sense to do a UPT, even if she is pregnant?
So, sir, firstly, about endocrine aspects of contraception. Firstly, a proper selection of the patient based upon the metabolic profile, the BMI, that is the weight, the glucose, and the hypertension, that should be kept in mind. Because we know that the combined oral contraceptive pills, they also tend to produce dysglycemia because of insulin resistance. They also cause a weight gain. And because of this, there is an increased risk of thromboembolism. So generally, for morbidly obese patients, we can try for other options like intrauterine device or progesterone only pills. That is one way of looking at it. Second, we also know that depomedroxyprogesterone acetate is also available, but then again the problem of weight gain and insulin resistance is there. That is one way of answering this question. About the second part of use of anti-obesity drugs and the patient getting to know that she is pregnant or planning for pregnancy. For generally patients who are planning pregnancy, we generally ask to stop these anti-obesity drugs at least for 8 weeks before the plan of pregnancy, simply for the fact that we do not have any data available about the safety of these drugs and the effect of these drugs on the baby. Once the pregnancy UPT test is positive and the patient is on these anti-obesity drugs, we need to withdraw them as soon as possible. And then later on, if we have a patient with ascites or other types of decompensation and finding out that the patient is ANC, the best way I would look at it is to refer the patient to the respective specialist, maybe because of the nephro reason or for the hepatic reason or for any other reason, and to take their consultation about what best can be done for this patient at this point of time.
And we need to work together. We need to have that humsuffer kind of attitude, the teamwork kind of attitude, and keeping the woman, the lady, the person who is trusting us with her own health and with the health of our baby as well. We need to keep her at the center of all our decision making and move together as a team. And if we just change the order of songs of Dhurandhar, so first it should be Ramba Ho. That's a happy song. I've prepared everything. The Dhurandhar song, the Fasla song. We are ready, and only then do you go to Piya Tu Ab Tu Aja and then you say that yes, we are able to plan pregnancy. So contraception first. Some other things I would like to add: if your patient is on semaglutide, whatever contraception is going on, you continue the same. If your patient is on tirzepatide, whenever you initiate tirzepatide or you intensify tirzepatide, the oral contraceptive absorption is going to go down. It is not going to be sufficient. So either you add a barrier or you shift to an IUD, intrauterine device. And now we have Silver Lily, which is a silver IUD, and you also have Progesterone Lily. The commonest brand name is Mirena. So these are things that you can advise to your patient when you are initiating tirzepatide or intensifying the dose. Do not make a mistake there. For semaglutide, whatever initial contraception is going on, you continue the same. If your patient is on lixisenatide, which is available as an injection with glargine, then the oral contraceptive should be given 1 hour prior to or 11 hours after the injection of lixisenatide. Now, as an endocrinologist, I would be the first one to admit that I am guilty. Always, I do not talk about contraception to my patient. There are multiple factors for me, usually social. If I'm comfortable with the lady, then I feel more free speaking with her. Otherwise, I come from a very conservative part of the country. Sometimes I feel shy. Even at my age, I feel shy. If the husband is with me, then I feel relaxed. Then I speak about contraception. I usually don't make a mistake. But if the mother in law is there, the father in law or father has come, then I get tongue tied. I am just not able to talk about it. I find that with practice, I have become better at speaking with the men. So even if there are 5 people, I can communicate with a male patient and understand if he has any reprosexual issue. But with women, I am not able to do. That is my fault. But to everyone who is listening to us today, whether you are on the right side of 40 or on the wrong side of 40, the right side is all our Dhurandhar speakers today, do make it a habit to talk about contraception. Either you offer the services yourself or you refer to the appropriate person. And at least barrier contraception is something that should be available in all our pharmacies. Remember again, lixisenatide, and tirzepatide, you have to change the timing or the mode of administration of contraception. And please do not make a mistake. If you are a cardiologist, a nephrologist, an internist, and your prescription is this long, all the more reason that you have to work harder. We'll move on, and there is this song in Dhurandhar as well, Move. So they talk about moving. So moving means multiple things, Dr. Tamir, doesn't it? First of all, moving means physical activity, and then moving means moving from reproductive and sexual age group to menopause. So let's talk about both. Physical activity in cardiology. I have never exercised in my life. I got an MI. How will you rehabilitate me? What will you tell me? How do I begin exercising?
So, in a lady, if she gets a MI, especially after post-menopausal age, the chances and risk increases multifold because the estrogen protective effect decreases and weight start increasing. And if patient gets MI and already she is not active, it is difficult to rehabilitate. Nowadays, especially physiotherapy units, post myocardial infarction rehabilitation units are available in many hospitals. If that is there, we generally refer to them. But usually, patients should start being active after 24 hours of the MI, and immediately without many patients get bedridden and they don't walk at all, they don't do any aerobic activities. But I generally advise to the patient within a week start some activity, initially aerobic activity, slow walking in the home, and gradually increase. Within a month, achieve the normal routine walking at least 30 to 40 minutes, slow walking, then 10 to 15 minutes, some yoga. If the LV ejection fraction is not very less and it is preserved, then do these activities, and as well as some weight training activities also, like some mild gym, 5 to 10 kg of weight gain training. Everything is important. Aerobic stretching activities, and muscle strengthening activities, exercises. And
And
for all these specialized physiotherapy units are there.
thank you, sir, for sharing the hierarchy as well. First, you get the patient to be flexible to do balancing exercise. Once the patient is able to balance after 24 hours, then they go to aerobics. Aerobics also can be low impact and high impact. Low impact means at any point of the time, at least one foot should be on the ground, like in walking. High impact would be at any point of time, both feet may be off the ground. For example, in Bhangra. So you have to start with low impact. And if the patient has got osteoporosis, osteoarthritis, it may be a good idea to postpone high impact exercises for the time being. And only then do you move to resistance exercise and you keep on building the resistance slowly. But Dr. Purva, from a nephro perspective, and our topic now is a lifestyle modification. We've talked about exercise. The rules are the same for all chronic disease, rehabilitation going slow and steady. But what about diet, ma'am? Any common myths that you see in women with CKD? Do they end up in malnutrition? What are the common myths and how do we address them?
So, of late, the common myths are that somebody who has chronic kidney disease, they should have a low protein diet, they should have a low salt diet. People start preferring pink Himalayan salt over the normal salt. And some people just absolutely remove fruits from their diet. So I'd just like to categorize what kind of patients should receive what. Basically, pink Himalayan salt is good for those who do not have any illness because it has potassium in it. But somebody who has chronic kidney disease, who has kidney disease, and even in the background of no kidney disease but a tendency to have hyperkalemia, especially when they are on ACE/ARBs or Findrinone or any drug that causes hyperkalemia, these patients should avoid pink Himalayan salt because or any salt that has potassium in it. In fact, even Tata Salt Light has potassium in it. So what they can simply do is check the nutritional um, information on the packaging, and they can see that the sodium content and the potassium content that should be checked. Usually, kidney disease patients should not have salts or any things that have potassium, excess of potassium in that. Those patients who just have plain hypertension, they will be benefited with some potassium supplementation. Now, as far as protein is concerned, somebody who's losing protein in their urine, they will need some amount of protein that needs to be replaced, and that should be done as per as your individualized nephrologist prescription. And the patients with dialysis also are told that you should have less of protein, which is sort of a myth which I'd like to bust. Is Indians usually tend to have a low protein diet. Most of us are vegetarians, very few of them, even if we in a country of 108 million people, it's not that all of us 100% are non-vegetarians or are consuming the protein that we require. So I would say anything between zero point 0.8 to 1 gram per kg per day for a patient who's on dialysis should consume protein. Protein can be plant based more so than animal protein. Red meat should be avoided. And lastly, one extra special comment on protein is a lot of protein powders that are being available in the market are adulterated with heavy metals, which leads to kidney disease. Now, everybody says that I've just started consuming protein powders in the last month, and I have started taking creatine and things like that. And they see a jump in serum creatinine from 1.2 to say 1.8. Now, we don't know if it is a bulky muscle or if it's kidney disease or things like that. But I would for sure be confident enough to say that protein powders, unless and until you are sure that they do not have any adulteration, should not be consumed. If you are consuming them, please check for the source, please check for the authenticity of the product. And as far as animal protein is concerned, it's not good for the heart as well. So red meat is not good for your blood vessels. It's not good for the vascular system. So that should be avoided. Smoking and tobacco use should also be cut down, or probably abstinence should be resorted to. And of course, alcohol should be moderated.
Thank you. Dr. Purva, you've hit upon a raw nerve in endocrinology as well, because we face the challenge is the same, the etiology is the same, unregulated use of proteins, but the impact is different in the OPD. So, Dr. Parag, anabolic steroid misuse, protein misuse, what are our young boys and girls coming with in the endocrine OPD, and how can we counsel them?
Uh, because of the propaganda all around of raw masculinity and of the fitness and of the newer goals, plenty of anabolic steroid abuse, the growth hormone abuse, erythropoietin abuse, those are actively around. The problem with these drugs is not a short-term problem; it is a long-term problem that also pertains endocrinology besides the other systems. The most important part of at least the endogenic anabolic steroid is the hepatitis that is happening. It is a hypogonadism that is happening there. It is the erythropoiesis or increase in the hemoglobin that is happening in those patients, leading to obstructive sleep apnea. And over a course of time, the patient are grossly a bulky looking male, but at the expense of their fertility. In the long term, they come to the gynec OPDs in search of ARPs. Again, with growth hormone, what happens is often the doses are not regulated and not according to the protocols, and the patients land up with all sorts of complications in the form of edema, arthalgia, myalgia, myositis. Needless to say, the worsening of any spinal disorders or pancreatitis that is often common. A common way and a proper way of advising these patients or these population is to advise about the proper use and a medical directed use of the drugs, which is directed to the individual appropriateness of the requirement. Protein powder per se, in the background of malnutrition, may be an appropriate choice, but not to the extent of over nutritioning the patient. A proper guidelines on the baseline indications, contraindications, and the follow-up of these drugs, and how do we plan to taper off these drugs from the patient so as to help and restore the endocrine hormonal balances is important. That's one way of counseling the patients.
The
And
best way is
also,
actually
like weight resistance training, that is important. Yeah.
the best way is if the
Yes.
patient has come to the nephro OPD, you say, of course, we have to take care of your kidneys, so you must stop these. But do you know that unregulated use of these proteins, which have heavy metals, they can impact your gonadal health? That hits the patient more. And if you're in the endocrine OPD, you say that that will hurt your kidneys, both the left kidney and the right kidney, and the heart as well, for good measure. And then you see that the impact is much more. But these are common problems in both men and women. Dr. Tamiruddin, we said that we'll move. So let's move to the last phase of life, which is midlife and the elderly. So in menopause, what happens to the cardiometabolic milieu? And is this true? When I was a student, we were taught that heart disease, cardiac disease hits Indian men when they are 40, 50 years old, but women are immune until 70. Is this still true?
So gradually this myth is busting. As I already told, yeah, more young females are already presenting with coronary artery disease because of newer modern lifestyle, unhealthy food habits, stress, and etc. But as well as once the menopause hits, the process accelerates very fast, and the lady should take care. And many times there are many myths like uh, hormonal therapy will decrease or it will stop the coronary artery disease, and they start taking it. So it should be advised to them that it is still risky and it increases the risk of coronary artery disease. And we are seeing the patient as early as 45 years with all diabetes, hypertension, and TVD, triple vessel disease, presenting with massive myocardial infarctions. And that could have been saved, that could have been treated earlier if detected earlier, if the patient was concealed in the past. So this is definitely a myth that females are immune to coronary artery disease till they are elderly. And in India itself, we are seeing this. It used to happen in West previously, but it is more common in India.
Thank you. Dr. Purva, one of your colleagues, Dr. Saurabh Sharma, a nephrologist from New Delhi, he sends this message that UTI is very common in women with CKD. UTI is very common in women who are post-transplant, and UTI is very common in post-menopausal women. So, basically, what hygiene measures can we share with women who are in post-menopause? He asks about the hygiene regarding UTI and also hygiene regarding bone health. So, what message would we like to give our internist friends to unmute?
So elderly women, they should not hold their urine in case when they are traveling for a longer distance and they find something which they don't wish to, a location where they are not comfortable to pass urine. That can lead to UTIs. That you hold your urine for a longer period of time. Also, the general hygiene that if you in also elderly women sometimes have incontinence because of obesity, because of lax abdomen and several other things, wherein they may have urinary incontinence on coughing, laughing, or whatever reason be. In these cases also, they need to have a hygiene that needs to be maintained, because even the soakage of frequently causing urination can also lead to genital and skin problems in these cases. The third category is if these patients are taking SGLT2 inhibitors and we know that they cause glucosuria. Even these cases have to have a stricter hygiene protocol because they are prone to fungal infections. So these 3 points I remember of as far as hygiene protocol for UTI prevention is concerned. And in case they have a UTI, or they have any symptoms, they should drink plenty of water. They can have cranberry juice if they are not having any background kidney disease. If they have some amount of kidney disease, if they are diabetic and they have uncontrolled diabetes, they should be taken care of.
There is this common practice to give nitrofurantoin, which is first line for UTI, and also to give alkalizer along with that. Would that make sense? Would you like to say anything about that? Or is it
Nitrofurantoin basically is acting on the bladder organisms, and in case you have pyelonephritis and that is undiagnosed and untreated, nitrofurantoin may not be the drug of choice for treating such uh,
upper
infections.
UTI? Yeah.
Yeah. So I would not give a blanket therapy of nitrofurantoin for every UTI being treated. I would prefer starting an antibiotic, but before starting an antibiotic, I'd send a urine culture. And based on the location of where I'm practicing, whatever organism is predominant, I'd like to give an antibiotic based on that.
So again, teamwork is required. Be in touch with the local microbiologist, the local physician, and the local imaging specialist, so that they know what they are searching for. If you send someone with UTI, they should know what they are searching for, so we can help our ultrasonology colleague also pinpoint and focus what is required.
Off late also,
Doctor,
we have a lot of MDR, so I don't think we should resort to nitrofurantoin.
yes. Dr. Parag, so much discussion going on around menopause. Now, a comment from the house is that menopause is a physiological part of life. Why are you people in endocrinology and women's health unnecessarily making it a medical issue? Why are you medicalizing something that is normal? So, your comments on this. Does a person going through menopause need medical support or not?
So, sir, menopause and the treatment around it has been a part of controversy since many decades. I believe we have seen all the ups and downs of all the therapies that are available. So those can be hormonal therapies or non-hormonal therapies. A patient who has a lot of hot flashes, those are intolerable for the patient, including the vulvovaginal atrophy and the dyspareunia or the itching or the burning micturition. And if they're not able to tolerate these with any of the non-pharmacological or local measures, and if the patient is just past a menopause, at least less than 10 years past a menopause, and the age is less than 60 years. If the patient does not have any active contraindication for the use of contraceptive, the estrogen plus progesterone pills, those patients may be considered for the use of menopausal hormonal therapy. Again, for cases of premature ovarian insufficiency, where we define as less than 40 years of age, those patients should be replaced with these hormones because a lady is not only about her menses, but also about her long term cardiovascular health, about her cholesterol, the atherosclerosis, about her bone, and about her hepatic health. So, those things also need to be kept in mind. Provided we are ruling out the contraindications, we are properly monitoring the patient, we are able to uh, follow what the patient is doing, how the side effects are happening, and how do we plan to tackle them. Menopausal hormonal therapy may be individualized and considered.
Thank you. We've gone through the entire phases of woman's life. We've talked of not only diabetes, but also cardiac and nephro health. And we've talked in general about over health. And I think that is the way to go forward, holistic health, working together, working as a team. We have so many drugs available now for use in diabetes. So perhaps the second last question for all our Dhurandhar panelists. Dr. Parag, dapagliflozin, sitagliptin, fixed dose combination is there. How do you use it in your practice?
Yes, I frequently use this combination of dapagliflozin plus sitagliptin. Most importantly, it is for the patients who I am concerned about the risk of hypoglycemia, about the risk of weight gain. Those are the patients, and where I know that a combined pill can reduce the pill burden for the patient. Those are the cases I like to use this drug. Beforehand, I like to rule out if there is any active genital infection or any contraindication like medullary carcinoma of thyroid or MEN2 syndrome or any active pancreatitis or past history of pancreatitis that is present for the patient that acts as a contraindication. Otherwise, I'm fairly happy with this drug, with this combination.
And Dr. Tamiruddin, the safety profile, the utility of dapagliflozin, sitagliptin, FDC in cardiology. What are
Yeah,
the caveats, considerations that we should be aware of?
yeah. Nowadays, dapagliflozin is more of a cardiac drug, and we are using very frequently, especially if heart failure with reduced ejection fraction is there. We start. It is the fourth pillar of the therapy, and this combination is very effective. Reduces the pill burden, reduces many complication. Apart from the previous history of UTI or prone to UTI, I suggest patient to take 200 to 500 ml water more to avoid chances of recurrent UTI or having a UTI.
So good hydration is required. And
Uh,
Dr. Purva, from a nephro perspective, the use of dapagliflozin, sitagliptin, what threshold should be aware of?
Actually, we prefer Lina Dapa over Sita
That's
Dapa.
fine.
And sitagliptin and dapagliflozin, they need a lowering of the dose of sitagliptin. So, in case they are already taking 50 milligrams of sitagliptin, then the GFR cutoff I think is 25, if I'm not wrong, and the dose of sitagliptin needs to be reduced. But linagliptin is the only drug class in the gliptin group wherein it does not require any dose modification, even if you're CKD5. So, as a nephrologist, we prefer Linadapa over Sitadapa.
That's fine. We should use the right drug for the right patient. If the EGFR, however, is above 50, then you can use sitagliptin as well in full dose. And below 50, perhaps 50 milligram OD will also work up till an EGFR of 30 or so. It's been great discussing this with you. And like we said, we've discussed virtually everything under the sun, including Bollywood as well. So, lots of thanks and compliments pouring in for all our Dhurandhar experts. Perhaps we could conclude with a take home message from all of us. So, Dr. Tamiruddin, our topic for today was the phases of life of a woman living with diabetes. Your take home for people who are with us.
Yeah, so women constitute 50 or more than 50% of the total population, and we as doctors, especially as cardiologists, we should take care every age group of the patients to prevent the heart diseases, to have a normal pregnancy. We should guide them properly. We should treat them if they have any diseases. After menopause, patients should be guided properly, and early detection of coronary artery diseases and other things should be uh, detected and should be treated on time.
The Urdu phrase would be mustaqbil a metabolism. That means the future of metabolism. And the future of metabolism, Dr. Tamiruddin, the future of cardiometabolism. Are you optimistic? Are you pessimistic? What do you feel the future is? Are we giving
Yeah,
better quality care?
yeah, I'm very optimistic about the future because we are becoming more and more aware about the things and the basic metabolism, basic pathologies, and people, general public is also being more aware, and we should be able to treat the things more appropriately in future.
Dr. Purva, your take home. In the title track of Dhurandhar, Ranveer Singh sings, Dance for me, it makes me happy. So now, with the newer drugs that we have, can the left and right kidney dance together? And more importantly, can they dance together with the heart and the pancreas and all the other organs of the body? What is your take for the future?
So my take would be, first I need to watch Dhurandhar because I haven't watched it yet. I think I have to watch it desperately now, listening to all the songs and all the phrases from Dhurandhar. But coming to the take home, I think if we are doing great practice, good clinical practice, the future is optimistic. There's no doubts about that. And I think such educational programs help physicians understand practice better. So that's my
I would
message.
I
Yeah.
would really echo what you said. So just good clinical practice and good clinical sense. That is all that is required. Common
Yeah.
sense.
Yes.
Dr. Parag is known as the Dhurandhar of academic endocrinology in India now, a very upcoming endocrinologist and famous, already making a name for himself in academic circles in and beyond Bombay, just like the Dhurandhar spy. So, Dr. Parag, your comment and a specific comment coming for you from Mrs. Agarwal. She says, "Lut le gaya dil." She says in Punjabi, "Dil loot ke le gaya." Again from Dhurandhar. So, your comments for all of us listening to you.
Yes, sir. At the outset, as I always say, a woman is not only about the menses. The woman has some unique characteristics to her, right from the intrauterine life, the prepubertal, puberty, preconception, conception, post-conception, premenopausal, perimenopausal, postmenopausal. So all of these aspects are characterized by dramatic changes in a lady's life, all of which affect all the endocrine aspects of the body, including the bone, including the ovaries, the cholesterol, and also the cardiovascular, hepatic, renal health. And each of these need to be kept in mind at the appropriate times of the life because it's not only about the woman, it's also about the future of the society that we are going to give to the next generation. So, keeping in mind all of these aspects, and an individualized therapy for the individualized disease should go hand in hand in a multidisciplinary setting. That's what I believe, sir.
Thank you so much, Dr. Parag, Dr. Tamiruddin, Dr. Purva, and thanks to everyone who has logged in with us. Uh, the nice thing is that we are all able to speak with each other, listen to each other. We are all able to dance together, and this is the dance of health, the dance of happiness. The other nice thing is that we understand that when we get together, we are actually able to ensure an optimistic, healthy future for us. And on this optimistic note, on this great note, I'd like all of you to join us in thanking our Dhurandhar speakers, Dr. Tamiruddin, Dr. Purva, and Dr. Parag. Team Mumbai, Navi Mumbai has done a great job today. I'd also like to welcome you to log in for our next session of 4D, Detailed Discussion and Dialogue in Indian Diabetes. This is a duologue that will continue. It's an infinite game, and we'll be together we'll join the karma, we'll join the suffer, we'll be humsuffers, we'll be traveling companions together towards a healthier and rosier future. Thank you, everybody. Thank you once again, Parag, Purva, and Tamiruddin. Jai Hind.
Jai Hind, sir.
Thank you, sir.
So,
Thank you.
thank you.